Now we're going to talk about the stage-wise treatment of ovarian cancer, and we'll start with the treatment of early stage. Okay, so if on opening the abdomen we see that the stage is like apparently, the stage is apparently 1 or 2, that is, it is limited to the pelvis. Okay, so it is an apparently stage 1 or 2. Then what do? Then we do something that is called as surgical staging. This is called as surgical staging, the procedure that we do. And what do we do in this surgical staging is that we obviously have to go via laparotomy. Okay, we give a huge midline incision extending from the symphysis pubis downwards to vertically up, and we will go quite high up. In fact, we have to go above the umbilicus, so it has to be a big midline vertical incision, and then we open the abdomen. And just as we open the abdomen, you know, if there is going to be ascites, right, it's going to come out immediately. So basically we give a big midline incision. Okay, a midline incision is used. Then what do we do next is if there is ascites, we go for the ascitic fluid sampling. All right, that ascitic fluid has to be sent for cytology, right? If there is no ascitic fluid, let's say, what do? There is no ascites. Then also we have to take the sample of the peritoneal fluid, and peritoneal fluid is very little fluid. So what do? Is we go for peritoneal washings. We put saline inside the pelvic cavity, wash inside, and whatever comes out, that is the peritoneal washings. So we take the peritoneal washings. We will also take the peritoneal washings for sampling. Okay, peritoneal washings, they have to be sampled. These ascitic fluid and peritoneal washings will be sent for cytology. Okay, so this is what is done. All right, the ascitic fluid sampling, peritoneal washings. After that, once we have washed the peritoneum, what we do is we have to inspect and palpate each and every nook and corner of whatever is inside the abdomen and pelvis before jumping onto the final surgery. So we have to take a look. So we start going in a very systematic manner so that we don't miss out any area, right? So what we will do is that let's begin from the right side of the patient. Okay, so we can start palpating and visualizing the areas. We start palpating, visualizing the cecum, and then the ascending colon, and then we go to the under surface of the liver and the diaphragm there on the right side, then go to the transverse colon, under surface of the diaphragm there, then reach the spleen area, palpate the spleens, look at the spleen, under surface of diaphragm on the left side there, then descending colon, then we come and start feeling and looking at the mesenteries of the small intestine. So feeling and looking at the same time is very important, because obviously if there are big enough deposits, you will see them. If they are not deposits to be seen, we palpate them. So any irregularity, any area we feel that is suspicious, possibly could be a tumor deposit, is taken out, biopsied. If nothing is found, everything is clear, then what do? We have to take representative biopsies from those respective areas. So everything is seen and palpated and felt, and finally then after that we move into the pelvis to take care of the tumor, to take care of the cancer there. So after peritoneal washing, we have to go for an inspection and palpation of the abdomen contents. So that has to be done for all the organs that I have described right now. Apart from that, what we also do is omentectomy. Very, very important question asked as a part and parcel of the surgical staging done for ovarian cancer. Omentectomy is always done, and omentectomy means removal of the infracolic. We do an infracolic omentectomy. We remove the infracolic omentum, and omentum is basically the area along the it's like a cover. Okay, it's like a cover of the abdominal cavity made up of peritoneum, and I told you that cancer ovary spreads by this peritoneal along the peritoneal surfaces. So this omentum, even though it might appear absolutely normal, needs to be removed completely. All right, so this infracolic omentectomy has to be always done. Then we concentrate on the rest of the pelvis. There we go for a total hysterectomy. Okay, we don't have to spare the uterus. Total hysterectomy plus bilateral salpingo-oophorectomy. Total hysterectomy plus bilateral salpingo-oophorectomy is done. After that, what about the lymph nodes? The pelvic and the para-aortic lymph nodes. I told you that they are positive. Once they are positive, that is called as stage 3, right? And they will be positive. How will we know if they are positive? We will have to remove them, see them under pathology, and then only say that they are positive or not positive, right? Now, it has been seen that tumors or cancers which are confined to the ovary, stage 1C specifically, cancers in which even though they might be confined to the ovaries, even though they might be confined to the pelvis only, all right, even then, deposits in the pelvic and para-aortic lymph nodes have been found, and if they are left behind, if these para and pelvic aortic lymph nodes are left behind, they can lead to recurrence. So they are always removed. They are always removed because the incidence of pelvic and para-aortic lymph nodal metastasis in apparently early clinical stages is also very significant. If we leave them behind, that can lead to recurrence. So that is why they should always be removed. Another important point is, so this pelvic and para-aortic lymph nodes, they are removed, okay. Then another important point is that if it is of mucinous histology, if mucinous histology is there, then we also do an appendectomy, okay. So this is the part and parcel of surgical staging, okay. This is the part and parcel of surgical staging, that is. So this is the basic outline of performing a surgical staging, which involves, alright, so I have to surgically stage. Now I'm a surgeon, I have my eyes and my hands at my disposal, right? So that is what I'm going to use, alright? So that is what is done. Careful inspection, palpation of everything that is in the abdomen, right? Ascitic fluid is sampled if present. If it is not there, peritoneal washings are taken, all right? After that, if no area can be seen, the pelvis and abdomen is entirely clean, then representative biopsies are taken. Omentum is always removed. Infracoelicomentectomy is done. And then the basic surgery is a total hysterectomy and a bilateral salpingo-oophorectomy, all right. And apart from that, the pelvic and the para-aortic lymph nodes need to be removed, even if they don't look enlarged. They have to be removed in an ovarian malignancy, all right. And after that, if it's a mucinous histology, we have to add one more step to it. Appendectomy needs to be done, all right. Now, what do we do in an advanced stage? This was about the early stage where we did a surgical staging, all right. What do we do in an advanced stage? When it is an advanced stage, that means it is stage 3 and 4. Okay, so what happened is, I opened the abdomen, okay, and I see that there is tumor everywhere. This is advanced stage. It has come out into the pelvis, gut deposits are there, rectal deposits are there, blood deposits on the bladder are there. It's all advanced. Then I do what is called as debulking surgery. Debulking surgery means remove as much as is possible. This is also called as primary cytoreductive surgery. Okay, that is called as debulking surgery. Okay. And when we do this debulking surgery, you have to remember that optimal debulking is considered if the residual tumor is less than 1 centimeter in size. So residual visible tumor should be less than 1 centimeter in size. That is what is called as optimal debulking, all right. Then there was in the past people used to do to check. People used to check for residual disease. By doing a laparoscopy, okay, by doing a laparoscopy to check for residual disease. But this is something that was considered a gold standard. This was something that was considered a gold standard. Now what has happened is that we have newer diagnostic techniques like PET scan available. This does remain a gold standard, you know, to look for residual disease. I would say yes. If somebody asks me that what is the gold standard to look for residual disease, of course you go inside and have a look. That is laparoscopy. However, I need to emphasize that it is something that it is not usually resorted to. Okay, it is something that clinically is not usually resorted to, and we can avoid this, and we rely on other PET scan or PET scan mainly. This is the new innovation in cancer. FDG PET scan is used, you know, to look for metabolically active cancer deposits, and in one whole body scan we can see if there are tumor deposits in the abdomen, pelvis, outside the abdomen, anywhere. So distant metastasis can also be recognized in this one single PET scan. So that is what is usually favored. But yes, this is a question that has been asked in the past, that what is the test to check for residual disease. That was laparoscopy. It was considered a gold standard to check for residual disease. However, it is not usually clinically indicated. However, not usually clinically done these days. Because of PET scan availability. Okay, so that is there. Now, so this is the main surgical treatment as far as the various stages are concerned: early stage, late stage. So now we'll talk about the post-op chemotherapy. Now, what happens is we've done the surgery, all right, we've done the surgical staging, or we've done the debulking or whatever. So when we've done the surgical staging, we've sent the uterus, the tubes, the ovaries, the omentum, and all these deposits we've sent. We've sent the lymph nodes that we've removed. All this and the ascitic fluid cytology, whatever tissue that we obtained during the surgery has been sent for pathological evaluation. So whether or not to give post-op chemotherapy will depend upon the final stage, and the final stage has come after reviewing the pathological findings, right? So the deposits that were sent from the representative biopsies from the abdomen, have they come positive, right? Or the lymph nodes that were removed and sent, which were not looking like clinically involved, they were not enlarged or anything, but yet removed and sent, have they come out to be positive for tumor on histopathology? So that is the kind of information we gain after doing a surgical staging. So after the surgical staging, what we do is we come at a final histopathological surgical staging. So we get the decision whether we give whether we give post-op chemotherapy or not. It is based on the final surgico-pathological staging that we get. Okay, now what is seen now? Post-op chemotherapy is given to all. It is given to all. It is given to all except, very, very important, except stage 1A or 1B and grade 1 or 2. Okay, so only in these stages, only in stage 1A or 1B and grade 1 or 2. Okay, so in early grades, grade basically denotes the tumor differentiation. Okay, grade denotes the tumor differentiation. Okay, so the grades 1 and 2 are the well differentiated and moderately differentiated tumors, and you can obviously say that grade 3 are the tumors which are poorly differentiated tumors. So grade 3, which are poorly differentiated tumors, they behave more aggressively as compared to grade 1 and 2. So when it is this early stage, stage 1A or 1B, okay, and grade 1 or 2, only then we can avoid chemotherapy. Otherwise, chemotherapy is given to all patients. And what is the drug of choice of chemotherapy? The drug of choice is carboplatin plus paclitaxel. Okay, if carboplatin is not in the option, then obviously cisplatin is the other option. So carboplatin and paclitaxel is the drug of choice. If carboplatin is not in the option, then cisplatin, and this carboplatin paclitaxel combination is continued for 6 cycles. So chemotherapy, very simple to understand, chemotherapy is given to all patients, only except when it is confined to the ovary, limited to the ovary. It should not be stage 1C. That is why I made you memorize stage 1C. Stage 1C is important because the tumor, the cancer might look like being limited to the ovary, but if on histopathology it shows that the capsule was breached, that is stage 1C. If on histopathology it says that though the tumor is limited to a single ovary, but the ascitic fluid has come out to be positive by cytology, then it is upstage. The final stage is now reviewed as stage 1C. Then we will have to give post-op chemotherapy. So stage 1C is the distinction here. That's why important to know 1C. Because stage 1C and beyond, you always have to give chemotherapy. Also, please remember, whenever it is clear cell histology, we have to always give post-op chemotherapy. Clear cell histology is considered high grade. So always give chemotherapy. Post-operatively, irrespective of whatever the stage, whatever the grade, these are always considered high grade. So irrespective of whatever stage they are, one should always give post-operative chemotherapy. Drug of choice is carbopaclitaxel. Alright, now we talk about the prognostic factors. So the prognostic factors for ovarian cancer, the most important prognostic factor is the stage. Okay, the final stage that we come to diagnose, the final stage, that is the most important prognostic factor. In fact, if the ovarian cancer has been diagnosed at, let's say, stage 1, the stage 1, stage 2 and stage 3 and stage 4, these are the 4 stages. Now the stage 1, when very early stage 1 like 1A, 1B, the prognosis is very good, about 90%, and drops down to another 80% when it is stage 1C. So therefore there is a range of about 80 to 90%. What is this 80 to 90%? This 80 to 90% is the survival rate. 80 to 90% survival rate. With stage 2 cancer, the survival rate drops down to about 60 to 70%. With stage 3, it's about 40%. So, and with stage 4, it's about 20%. So you can remember this basically 80, 60, 40, 40 as the survival rates for the different stages of ovarian cancer. The most important prognostic factor is the stage, which determines the survival rate. Okay. Then the other important prognostic factors are basically all the factors which determine the stage. All the factors which determine the stage separately are separate prognostic factors. Like obviously we have like I told you, that clear cell histology is poor prognosis. Okay, like I told you, the age of the patient, if she is older, then there is poor prognosis. Okay, then we have the residual disease after debulking. If we are not able to completely debulk the tumor, then also this prognosis worsens. If there is malignant ascites, then also the prognosis is bad, and of course the tumor grade. Okay, and of course the tumor grade. So these are the factors which also affect the prognosis. So these are the individual factors which affect the prognosis. Okay, clear cell, age of the patient. If after debulking we have not been able to remove the complete tumor and much of the tumor is left inside, malignant ascites and tumor grade, these are additional features which affect the prognosis. And most of these, like malignant ascites and tumor grade, these are separately written. Okay, because malignant ascites though is a part of staging, but you have to understand that why I want to tell you about these factors is that if two women are in the same stage, If there are two women who both are having the same stage, both are stage 1, let's say, then who has a better prognosis? The one which has a good histology has a better prognosis. If the woman has a clear cell histology, then it is bad prognosis, right? If the woman is older in age, she has a she has a poorer prognosis. Another important thing, if there are two women, both 50 years of age, both stage 3, and we've done a debulking surgery for both of them, the better survival rate, better prognosis is in a woman in whom the disease has been optimally debulked. That is why residual disease after debulking is a prognostic factor. Okay. And tumor grade, of course, higher grade tumor means poorly differentiated. That means that there is poor prognosis. So of course, that is why they are also subjected to post-operative chemotherapy. So this is about the prognostic factors of ovarian cancer. Now we're going to speak about the last lot, that is fertility sparing surgery. Fertility sparing surgery. Now, ovarian cancer is a condition where the surgery involves losing fertility. Both ovaries are removed and the uterus is removed. So, can we offer fertility sparing surgeries to ovarian cancer women? The question is arising only if it occurs in younger women. So, most of the times fertility sparing surgery is not an issue because most of these women are postmenopausal, but sometimes fertility sparing could become an issue if there are younger women involved, right? So, fertility sparing surgery is done only in stage 1A, only as long as it is confined to a single ovary, only when it is grade 1 or 2. So, only in the early stages is fertility sparing surgery an option. Alright, an important point is when we spare the fertility for such women, it's not like we don't do anything for that women. What we do for these women is a unilateral salpingo-oophorectomy. Unilateral salpingo-oophorectomy, the affected ovary and tube is removed, agreed. The uterus and the other side ovary can be preserved, but a thorough surgical staging is also done. It's not like the rest of the surgical staging should not be done, because the final decision whether we could continue with this fertility sparing surgery or she needs chemotherapy or not will depend upon the final histopath. So that is why the final surgical staging is very, very important, right? So fertility sparing surgery is done only in the early stages. And there was a question in the exams which help you understand the importance of this information, right? There was a question which said, let's say, I'll give you the question, that there's a 30-year-old woman, okay? There's a 30-year-old female who is nulliparous, okay? Who is nulliparous, and she had a unilateral adnexal mass, okay, and she underwent a cystectomy. So somebody for an adnexal mass in a 30-year-old woman, not wrong, because most likely benign masses are there, and most likely when the person must have opened the abdomen, the mass must have looked benign to him, okay, considering that he was a good doctor. What he did was a cystectomy. So a cystectomy was done, and once the cystectomy was reviewed, the histopathology, in the histopathology, it came out to be serous cystadenocarcinoma. So uncommon, but yes, can be found, right? So a young woman, nulliparous woman who underwent a cystectomy for an adnexal mass, and the histopath unnaturally and unfortunately came out to be a serous cystadenocarcinoma, a cancer. What do we do now? What next? Now, in this particular question, she is nulliparous, okay? In this particular question, she is nulliparous. So, the issue of conserving the fertility arises here, alright? So, what we can do for this woman, is a unilateral salpingo-oophorectomy plus surgical staging. So, a completion surgery, staging is a must. Okay, so if fertility needs to be conserved, example in this particular case, we can go for a unilateral salpingo-oophorectomy and a surgical staging. She has to be staged again because the histopath has come out to be serous cystadenocarcinoma. The ideal thing to do would be to go for a unilateral salpingo-oophorectomy, remove the affected side and go for a complete surgical staging. This has to be done. If this is not in the option, then the second choice could be follow up with CA125 levels. Follow up with CA125 levels is a second choice, is my second choice. The best thing to do in this scenario is a completion surgery. But yes, since fertility needs to be conserved, we can go for a unilateral salpingo-oophorectomy plus surgical staging. According to the surgical staging results, if it comes out that the staging has been upstaged, then our treatment will change, all right? But we're not going into the details of that. What I want to tell you is that fertility sparing surgery is an option, but only in situations where the tumor is apparently confined to single ovary and final histopath comes out to be stage 1A grade 1 or 2, right? So right now in this situation, the best option for such a woman would be to go for a unilateral salpingo-oophorectomy and a complete surgical staging, which was not done earlier. If this is not in the option, if this best scenario is not in the option, then we can go for follow-up with CA125 levels also. Okay. Now, if this same woman was multiparous, if this same woman was instead of being nulliparous, this 30-year-old with an adnexal mass with serous cystadenocarcinoma would have been multiparous. If she would have been multiparous and preserving fertility would not have been an issue, I would have gone for completion surgery. By completion surgery, I would have meant a hysterectomy, BSO plus surgical staging. Okay, surviving is more important in terms of cancer rather than childbearing, right? So since her family would have been completed, if she was multiparous, even if she had one child, and I would have told her that you have been diagnosed with a cancer on single side of the ovary, if you have no other future childbearing needs, you don't want a second child, it is a good idea to get a completion surgery done. Okay, so that is what is important to remember.